Hello guys. So in this video we are going to discuss about the methods of banding and bonding in orthodontics. So we all know orthodontics is basically is revolves around the appliance components which is banded or cemented to the tooth structure. Commonly nowadays there is direct bonding of the brackets and the molar tubes to the tooth structure so that the wires that can be placed over the bands and the bonded attachments will bring about the tooth movement. So how do we band? What are the materials used? That's is the scope of this video. So there are some important MCQs that are associated that are being asked regarding the bonding procedures, the materials used for bonding, the different innovations in the bonding materials, which we'll be discussing in this lecture. So we'll start with banding. So initially, what was happening was they were separately banding each tooth and then welding the attachment to the bands and then cementing the band to the tooth structure. But this was taking a long time and it was also not looking good. And we need to separate the tooth before banding each tooth. So it was a very tedious process. So after development of bonding, nowadays everybody directly bonds the attachment to the tooth surface. So currently banding is confined only to the molars and the second first and the second molars in some situations where the bonded attachment is coming out, not sticking to the tooth properly, not adhering to the tooth properly, there is a repeated debonding. In some situations we can band the tooth, but it is not being done very routinely. So what are the steps in banding? Direct banding nowadays, preformed bands are available with the attachment welded, ready made. So what we need to do, the first step is tooth separation. As you can see in this image, teeth generally has good contact with each other. So we'll not be able to place the band around the tooth because the contacts will prevent the bands from seating inside the contact point. So we need to place something called as separators. So these separators are placed between the contacts of the tooth so that after 2-3 days there will be slight gap developing just near the tooth surface, so we can easily place the band around the tooth. So there are different types of tooth separators. The first, you can see, this is a spring. This spring is called as a Kessling tooth separator. So this is made up of a stainless steel wire and it is fabricated. It has a scissor-like action. It goes into the contact point. One arm goes above, one arm goes below. So it has a scissor-like action. It moves the tooth away from each other and the gap is created. So this is called as a Kessling tooth separator and it is one of the methods of separating the tooth. One of the common method used is an elastomeric separator. If you have seen during your UG days or whenever you have seen any patient, you would have placed a separator, also few of you would have. So this is the separator placing forceps that you can see here. So this separator placing forceps expands the elastomeric ligature, squeezes the elastomeric ligature into the contact point of the tooth, and then you keep the elastomeric ligature for some time. This elastomer material absorbs water, swells up a little, and then kind of pushes the tooth away from each other. This generally takes 2 to 7 days for the separation to happen depending on the tightness of the contact point. So what are the other methods of using a separator? Separating a tooth. One is a brass wire. Take a soft brass wire, put it around the tooth and tighten it. This method is one of the most earliest methods of tooth separation. It is a very painful procedure. Placing a brass wire and taking it out is a very painful procedure. So nowadays commonly elastomeric separation only is done. So you can also use an elastic thread, put it around and tie a knot between the tooth. This is also one of the earliest technique to separate a tooth. This is called as a dumbbell separator. It's the shape of a dumbbell. It is placed, can be placed. One of the nowadays most common method of separation is the elastomeric O-ring separator. So this is basically what you need to remember in banding. So banding, you need to know about the different separators. It's a very important short notes if you're a final year student. and it is few questions here and there do come from separators, how long the separator is kept for. They can show you an image of a Kessling separator and ask you what type of separation it is. So all those things are being asked. And coming to bonding in orthodontics, so in 1955, one cutting edge invention happened, which was a Bunocore. He is the one who invented the acid etch technique. It's an important one mark question. Who invented the acid etch technique can be the question. So, Bunocore invented the acid etch technique using 85% phosphoric acid. So, after the development of acid etch technique, BIS GME or the composites were developed. So, after that, after 1980s, everybody shifted to direct bonding in orthodontics. So, what is the advantage of bonding? It's very simple. It's it's more aesthetically pleasing. It's quick to do. It's less comfort for the patient. You can precisely place the brackets, improved gum condition. So all these can be done. So what is the basis of bonding? So how does a orthodontic bracket bond to a tooth structure? It bonds by means of something called as micromechanical bonding. It is not chemical bonding like your cements. It is micromechanical bonding. So what happens? This is your tooth surface. Now you are going to add an acid, which is 37% phosphoric acid. You are going to add an acid, remove some amount of enamel from the surface. So you create a porosity like surface on the enamel surface. So there's a porosity. So these are micro cracks or micro surfaces. You're creating a little uneven surface. Now you're going to place a composite over it. So this composite goes inside these cracks and fills the cracks. So micro level, there is a mechanical bonding of the composite into the cracks. So this is called as micromechanical bonding. So this is a conditioned surface. You can see there are cracks on the conditioned surface. Conditioning means treatment with the 37% phosphoric acid. Unconditioned surface is when you do not treat a surface. So you can still bond the composite. You keep a composite, you're going to cure, it's going to be there. But it is not going to stay on the tooth surface because enamel is a very smooth surface. So use of this 37% phosphoric acid is a very important invention because you place a bracket and then place the composite on top. So the composite is going into the tooth structure and it is holding on to the tooth structure. So this process is called as micromechanical bonding. The principle behind orthodontic bonding is micromechanical bonding. So what are the different types of bonding? So you directly etch the tooth, place composite on the bracket and directly position the bracket individually for each tooth. It is called as direct bonding. There is something called as indirect bonding. What you do in indirect bonding is you take a cast, you position all the brackets properly, take putty material, place it on the brackets, transfer the entire brackets onto the patient in toto, not just one bracket, all the brackets together. It is called as indirect bonding. One disadvantage of indirect bonding, it's a little tedious process, but the positioning, since you are doing it on the cast and then transferring it, the accuracy of the positioning is much better compared to your direct bonding because some amount of error can be there during direct bonding. However, direct bonding is usually preferred because it's less time consuming. You need not sit and work in the lab by placing the brackets. So this is much convenient for everybody. So direct bonding is usually practiced. So we are going into the steps in direct bonding. First, before bonding any tooth surface, for proper adhesion of the composite to the tooth surface, the teeth has to be cleaned. First, the scaling has to be done and the teeth has to be cleaned with the pumice. Pumice polishing has to be done. This will remove any sort of plaque and organic pellicle that is sticking onto the tooth. Even after scaling, some amount of pellicle might be sticking to the tooth surface. Hence, proper polishing with pumice is essential before bonding the tooth. Next, you're going to have proper moisture control. Only then the adhesion between the bracket and the tooth is going to be good. So you can keep saliva ejectors, tongue guards, salivary duct obstructors, cotton rolls, anti-silagogue in small children who have like severe salivation, which is not able to be controlled using mechanical moisture control. You can use pharmacological methods of moisture control also. Next, so coming to the enamel pre-treatment. So after you have cleaned the tooth surface, you have given good moisture control. Now you are going to etch the tooth which you need to bond. So the most common method of etching the tooth or conditioning the tooth is using a 37% phosphoric acid. So 37% phosphoric acid generally gives the required micromechanical adhesion. If 37% phosphoric acid is not available, you can use the other methods also. This is an important 1 mark question. So it's usually asked what are the which one of the following acids are used for enamel pre-treatment, or which one of the following is not an acid used for enamel pre-treatment. So 10% malic acid, 50% tannic acid, and 50% citric acid. All these can perform similar to 37% phosphoric acid. So usually 37% phosphoric acid can be etched on the tooth surface for 15 to 60 seconds. In patients who have fluorosis, so this could also be a question. Do you increase the etching duration? Yes, you have to increase the etching duration by 10 seconds. So fluorotic enamel fluorohydroxyapatite enamel are slightly resistant to acid attack, acid dissolution. So you can etch the fluorotic enamel or patients who have fluorosis 10 seconds more than what is generally done for normal patients. Also, if you are etching a primary tooth, for primary tooth also, the etching time must be extended because primary tooth has something called as aprismatic enamel. Aprismatic enamel are much more resistant to acid etching compared to normal enamel. So for fluorotic patients and in primary tooth, the etching time can be slightly increased. So you apply you can see the blue color gel. So etchants are available, 37% phosphoric acid are available in the form of gel as well as liquid. Mostly gel form, the two blue colored. A contrast color is preferred because it is easier to clean up. So if it is a liquid which is white in color, we may not know if it is still being adherent onto the tooth. If it is slightly colored and it is also gel, it is easier to wash away after the etchant procedure. So usually it is blue in color, which is in contrast to the mucosal color, which is red color, and apply the gel only in the area where you need to bond. You're not supposed to etch the entire tooth surface. Then after 15 to 20 seconds, wash out the etchant using your three-way syringe and clean up, dry it. You will see something called as a dull, frosty white appearance. You will have a very dull frosty white appearance. This indicates successful etching of the enamel. Dull frosty white appearance is what you should be able to make out. In case there is when you're washing it, there is again saliva contamination, patient moves their head or accidentally places their tongue onto the tooth surface, you're supposed to re-etch the surface for another 5 to 10 seconds. So re-etch the enamel if there is any sort of blood or saliva contamination after etching or after getting the frosty white appearance for 5 to 10 seconds. So this appearance is not there, then you have to re-etch the tooth surface again. So dull frosty white appearance is what you need to look for after drying the tooth. It is not seen in a wet tooth, it is seen in a dry tooth. So Silverstone classified 5 types of etching pattern. This is also an important short notes question. So when the etchant is kept for some time, the dissolution of enamel creates a pattern. So this pattern can be classified into 5 types. First type is initially prism cores alone. You have all read about the structure of your enamel. There is prism. The enamel prism has a core and a periphery. So in the type 1, only the core is dissoluted, resulting in a honeycomb like structure like this. only the core gets removed. So the honeycomb like structure will be there. In type 2, prism peripheries also dissoluted. So it looks like a cobblestone appearance like this because the peripheries are also gone. Type 3, it is a mixture of type 1 and type 2 pattern. Type 4, pitted enamel surface, unfinished puzzle. Like both prism core and enamel peripheries are gone. So unfinished puzzle like appearance. Type 5, most of the enamel gets dissoluted. It has a flat and a smooth surface. Generally, type 4 and type 5 are not preferred for enamel bonding in orthodontic treatment. Type 1 and type 2 or honeycomb appearance is generally preferred as an ideal etching pattern for enamel. So this was classification was given by Silverstone. So this surface irregularity you can see microscopically is seen intraorally as a frosty white appearance as you can see in this image. So, are there any other methods instead of acid etching, instead of not using the acid? Can we use any other technique to, prepare the enamel for bonding? Yes, there are three other methods. There is something called as crystal bonding. You create crystals, micro crystals onto the surface of the tooth, and you attach the composite onto the crystal, not onto the tooth surface. Then there is something called as air abrasion. You use silica particles, aluminium silica to be exact, Al2O3 particles. You abrade the tooth surface with silica, aluminium silicate particles, and which creates the irregularities that is generally created by acid etching. And you can also use laser for etching the tooth surface. So if they ask any other methods of enamel pre-treatment, you could talk about crystal bonding, air abrasion, and laser etching. So what is the next step? After you have etched the tooth, you have dried the tooth. Now you have a frosty white appearance. Now you have to apply your primer or sealant. So sealant helps in bringing the tooth surface, creating a more conducive surface for the composite to come and bond to the tooth surface. Generally, a thin layer of sealant is applied onto the tooth surface, can be cured for about 10 to 20 seconds, and then the composite with the bracket can be applied. Advancement in relation to primers is something called as a self-etching primer. So generally, there is two bottle system, right? One etchant and then you go for primer. So in self-etching primers, the etchant and the primer are together. So from combined etcher and primer. So this decreases your time. First you need to put the etchant, then you have to wash it, then you have to put the primer, then you have to cure it. But if it's the etchant and primer are in one shot, you are going to reduce your chairside time. So basically the self-etching primer in orthodontics are supplied in the form of lollipops. Self-etching primer lollipops. So this is a methacrylated phosphoric acid which dissolves the calcium from the hydroxyapatite. So the removed calcium forms a complex and it incorporates within the composite matrix as the primer polymerizes. So there is minimal etching and more of a chemical bond with the calcium and mechanical bonding achieved with the enamel. So it is more a chemical bond with the calcium in than the mechanical bonding achieved with the enamel. So normal etching and priming is more mechanical bonding, and self-etching primers have more chemical bonding with the calcium. So this you need to remember. Self-etching primers are one of the advancements in the orthodontic practice. So you have done the priming, sealant application is done. Next you are going to place the bracket onto the tooth surface. That is bonding. So first is transfer. You take the bracket. This is the orthodontic composite that you can see here. You're placing the composite onto the bracket surface behind the bracket generally has a mesh that is of different forms. The mesh will help hold the composite onto the surface. So the mesh onto the mesh you place the composite and then you position the bracket with the composite on the tooth surface. You press the bracket so that the excess comes out. As you can see on the top, the excess composite have come out. Now you are fitting, positioning, adjusting the position of the bracket, removing the excess, removing the excess, because composite excess when left onto the tooth surface can act as attracting sites for plaque retention. So there will be a lot of plaque accumulation and associated gingival inflammation will be seen. So removal of the excess before curing is very very important, and once the excess has been removed, you're supposed to cure the bracket. So what is used to cure the bracket? Initially, conventional halogen lights were used. Argon lasers and plasma arc lights were initially used. The most commonly used method of curing composites, not only in orthodontics but also in other fields in aesthetic dentistry, conservative dentistry, all those is LED lights in the blue wavelength. Blue wavelength is about 450 to 500 nanometers. This is the wavelength of the blue light. This light is what is used for curing the composite. So once you have done with the curing the composite, the bracket is now secured. So your entire bonding process is complete. Thank you.